before, so good that this two talks were added. So after the first session, I was about to get converted totally. So, but so it is like a IPL. So sometimes you hit six, but sometimes you get out also. So just getting back to the reverse shoulder, there are indications which we need to understand. There are almost more than 50% with this PROFER trial may be conserved. When you have contact, impaction of the head and shaft, humor head not dislocated, minimal varus, minimal displacement, obviously will conserve. And this is the famous PROFER trial that is often quoted for proposing conservative trial. Important message is there is no difference between surgical and non-surgical treatment. Surgical intervention was considered, which was lock plate fixation and hemiorthoplasty. Reverse was not considered in this, which is now in the PROFER 2 trial. We will await this result of PROFER 2 trial, which was supposed to get over in 23. So reverse, the most of these fractures were two-part, with or without GT. They were 80%, and these were excluded dislocation of the fractures. So almost 32 centers. It was conducted between 2008 and 11, and 231 patients and 2-year follow-up. This was something which was a strong point of this, and the non-operative treatment was more or less similar, and they followed up with 6, 12, and 24 months. And there was no significant difference in Oxford shoulder score overall 2 years. So the conclusion of this was no significant difference in secondary outcomes, health-related quality of life, complications, and mortality. However, we are awaiting for this trial, which will be PROFER 2 trial, which will compare reverse shoulder vis-a-vis hemi and non-operative treatment for acute 3 and 4-part fractures. But before we get the results of this, we already have pooled analysis and systemic review, and this is in 2024, and reverse shoulder and non-operative treatment. And what it concludes was functional outcome and range of movement after RSA are far satisfactory, potential superior to non-operative treatment, and complication rates were low, though they are not zero. They are around, revision rate is around 5%. So it is, there are another trials. These are all randomized controlled trials, so grade 1 evidence, Dalvie trial. So it is superior to plate fixation in elderly. Okay, that's 2024. Just few examples. This was 25. Then we have Jan 26. The surgeon tried to follow the PROFER trial, and this was in 26. So perhaps we don't know which would, considering the age, and she had undergone CABG, and there were alternately ureteric stent. We don't know which patient will do well with this conservative trial and which would not. The PROFER trial gave liberty to the surgeons to decide the treatment. They were not truly randomized. They were excluded. So this doesn't predict. And if you see the CT, you can see almost like a shell. You know, there is hardly any bone and nothing. No fixation would work here. And this, we would not keep a standby, but this would be a primary reverse shoulder, because when it is a conversion of failed hemi or failed fixation, the results are not as good as doing a primary. If you do you may opt for acute conversion to RSA, or you may do it in a delayed manner. Results are more or less similar as long as the shoulder is a virgin shoulder. So that's, yeah, I think it was a right decision. These are clips of CABG. So there are indications. So more than perhaps 65-year unreconstructible, more than that, unreconstructible, highly displaced fracture, head split, failed proximal humerus, and one of the options, failed hemiorthoplasty or symptomatic malunion. And Pascal Bolu has classified these in 4, which I will touch upon. We would tend to do a hemi not because it was good, but it is easier to do it. We are able to do it, but the success of hemi would depend largely upon the union of the tuberosity in a right position, isometric position. We have this Sherpa trial, it shows that there is a superior functional outcome of reverse as compared to the Hemi, and this is in patients of 65 years and older. This is a prospective, multicentric, randomized trial, grade 1 evidence. So if you see the trend in US now in 2022, if you see the ORF, they don't have to have as competent and expert surgeons as Dr. Harshad and Kale and Dr. Pradeep Nemade. So overall ORF incidence going down to as low as 29. This I am talking about in elderly. Even the Hemi is going down to almost 4%, and the rate of revision, rather reverse shoulder is increasing because of the predictable result, the only surgery that it would require, and the results are good. So if you see the survival shape, this is around 82% Hemi at 10 years, 75, 20 years in a well performed Hemi, whereas total shoulder would be in that range, and reverse is around 91% of at 10 years. But do these, this is survival of the prosthesis, but do the patients survive so long? They don't. The 10-year survival may be only 47% or so. And when we are doing this reverse shoulder, it is a different animal altogether. When we are doing it for the trauma and when we are doing it for the rotator cuff insufficiency. So whenever we are doing for the trauma is an acute scenario, and the instability is a major problem. So that dislocation rate, and you have to choose the implant, which I will touch upon. So rather than loosening, where we have, these are usually elderly patients, so loosening is not more of a problem, but dislocation is a problem. So we have classical Paul Gramont's, just focus on the second line there, dislocation. So the Paul Gramont's prosthesis was a more medialized prosthesis, and it had a higher rate of dislocation. Vis-a-vis now we are coming out, we have availability of prostheses which are more lateralized. It's like a hip where you have more horizontal offset and the stability is better. So now the preference is for the lateralized sort of so these are the issues. So for whenever we are doing it for the trauma, as long as you are doing it for the rotator cuff insufficiency, it's different. But whenever we are doing for the trauma, initially we thought don't bother about the tuberosities, we don't depend upon the tuberosities, and even when tuberosities are not there, it will work. But now as you refine your techniques more and more, and you know the difference, you would like to have these tuberosities united. Even if they don't unite, try and get them back so that your function is better. So you have to choose your prosthesis. There are onlay and inlay. Classical Gramont's prosthesis was inlay, and it was a 155 angle, and it had a higher scapular notching. So onlay prosthesis is better there. Neck shaft angle, 155 did not require tuberosity union. The neck shaft angles, if it is in slightly varus, around 135 or 145, tuberosities can unite. So if you want the tuberosities back, and if you want external rotation, then you would choose a prosthesis which has a lesser neck shaft angle. Then we have conventional versus vis-a-vis fracture stem. So fracture stem has holes there to put the tuberosities back, proximally coated, and that is presently better. So tuberosities healing is preferable. It may not be achievable every time. It will have superior functional outcome, increased range of movement, active elevation, external rotation, lesser humeral side loosening, which is not a problem in an 80-year-old person, fewer complication, and increased survival as regards the revision. So if you see this, you have more concavity compression in 155 degree as opposed to 125 degree, and more stability in 155 degree, and the flip-off side is you can have increased, increased notching. So you have to choose your prosthesis. So I'll just, and tuberosity union, there are nice techniques which have been described, which is one of these is around, which is known as a nice knot technique. So classically, I don't want to name the prosthesis, but classically we used to, the first prosthesis which was available in India was Evolutis, which is a gray one here. So it is here somewhere. So jump height is smaller as opposed to what I am using now. I am not, please, I am not promoting any prosthesis, but if you see this comprehensive, it's a highly lateralized prosthesis, lateralized glenoid and lateralized prosthesis. It has got a better offset, better deltoid wrap angle, and better stability. So having burned our fingers, what would work very well in the classical medialized, medialized glenoid prosthesis, which is here. Just one of the example is unique reverse. It may not work every time in a trauma scenario. And whenever we are doing it for the trauma, I think we also, like we in the hip, we go through the test of stability. So we have various tests of stability have been described. Classically, one is this is a bed shuffle test. Classically, the patient is trying to get up, resting the palm and trying to get up. So that you test it on the table and see the stability. And another one is a lateral thrust test, which you would test. So these will tell you perhaps it will not dislocate. So one of the advantage of this, as I told you, if you see the global offset of this is amongst available, perhaps the largest global offset, which I would go for it for the sake of the stability. So this is the same thing, jump height and the stability ratio, which is described, and the area of coverage is very, very good. I will just go through the examples. So this is a 4-part, and in these cases, I am not as expert in fixing this, so I would be comfortable, would like to give a definitive one-time solution to this, and in my hands, one second. So if you see, this patient surprisingly also had I don't know whether this patient. Yeah, so this patient had a glenoid fracture as well, but you can manage this. It was undisplaced, and you can do a reverse shoulder. So that was the, and you keep the cemented one standby, but you can do uncemented one in these. So that's somewhat another one, 4-part, 80-year-old, slip and fall, and same thing. And you can do that. So here tuberosities, I tried to put them back. They are, since you are distalizing it, you can't get the tuberosities back to their isometric position, but getting it down is helpful. This is something useful, interesting. The patient presented 8 months after the initial injury, and there were failed attempts of open reduction. He was, somebody tried to attempt it elsewhere, and if you see the head was dislocated. He just couldn't get the head back, and he abandoned the surgery, and he left it just like that, and patient was painful. He was a taxi driver, and we got his, if you see these vessels, they are just, the brachial plexus and the vessels are around the head, So I thought of getting it out, but then I preferred to leave the head there because it didn't matter, and did this. That's the, now it is more than around 10 years. He's active in his profession, and if you get the, this is a sort of a debut original Paul Gramont type of prosthesis, 155 angle, didn't depend upon the tuberosities. That's the range you would get, external rotation and all. It's very happy and it's going on. It's a cemented prosthesis, so most of the times you would get this kind of range, which is not possible in when you do a hemi or fixation. Or another one, so again 11-year follow-up. That's the range, and active elevation and abduction, that is what you would expect to get. So we have this series in the literature, more than 79, mean age is 79. These results are satisfactory, reproducible, and sustained over time. That is what is important. 91% survival at 20 years. So that's good. The patient survival, as I told you, is not, the patient may not survive, but so the prosthesis outlives the patient. Complications are there. instability 2.5%, humeral loosening 3.5%, glenoid loosening. So tuberosity reimplantation, more important. Now, if you do a primary RSA vis-a-vis when you are doing a revision RSA for the failed orthoplasty, and there is a difference. The survival, I'll take 2 more minutes. The survival, there is a difference, okay? So the survival of the primary RSA is far better than one when you do it for after failed fixation or, failed hemi. So remember, that's the 10-year result, 15-year result, constant score, very good, okay? Cost effectiveness, it does work if you compare the non-operative one, and the ORF, hemiorthoplasty, and RSA. Surprisingly, it is cost effective as compared to non-operative also, okay? That's just follow this, and the quality adjusted life years. So this is the American data, we may need to do it in our setting, and these are the possible sequelae of the untreated ones, perhaps they prefer trial or so. So we have, there is a classification and there is an algorithm. So if you have type 1 or 2, you may get away by doing anatomical, just the hemi. Type 2 can be fixed, but the type 4, you need a reverse. Which is better? Again, acute, primary or delayed primary. For primary humerus fractures have equivalent outcome. The acute primary RSA significantly outperforms the RSA done for failed ORF or failed. So in summary, RSA for 3 and 4 part humerus is a procedure of choice. Functional outcome is better with less reoperation rate. It is cost effective and it is better primary. If you feel that you cannot fix it well, then it's better to leave him alone and do it in a delayed manner rather than doing something, slipshod job of ORF or hemi. RSA is better than non-operative treatment. Thank you.